Peter, tell us about the DPP-4s and what happened in heart failure. What's the story there?
Well, recall that DPP-4s are dipeptidyl proteinase inhibitor 4, so they inhibit the breakdown of GLP-1.
They're not a GLP-1 agonist.
Right, but they inhibit, the drugs inhibit the enzyme that breaks down GLP-1. They lower hemoglobin A1C, completely neutral on blood pressure, neutral on weight, and were completely neutral on the MACE outcomes. But again, because of this theme, the reason why people wanted heart failure to be adjudicated is that we had previously seen a signal with the T2D class, and there was a concern that with drugs that don't cause hypoglycemia so much that maybe the MACE is not such an appropriate safety endpoint. Maybe heart failure should be in there. There was a push to have heart failure in these trials, and with one of the DPP-4s was alogliptin, there was a signal that those randomized to alogliptin had higher rates of heart failure that to this day are not explained. It wasn't seen in any other DPP-4 agents. Now, I imagine with GLP-1s and SGLT2s coming on, DPP-4 use may trail off right now, but they still have a large percentage use in type 2 diabetes.
Yeah, and saxagliptin and SAVOR was sort of the first problem with heart failure in the DPP-4 class. But then two other studies, Carmelina and TCOS, not seeing it. So it's not been a consistent finding, so it's a little more confusing. But the lack of cardiovascular benefit has really shifted attention, I think, to these two other classes.
Where the benefits are really clear. And
yeah.
that debated outcome with heart failure that
yeah.
we saw in the DPP-4s is off the table.
Right.
Positive decrease in heart failure with the SGLT2 inhibitors. No worsening of heart failure and a trend in the GLP-1 agonists. So, you know, one of the things we did was we looked at the ACC pathway, which was endorsed by the ADA. And Melissa, I think you know a lot about that. How does that help the clinician?
We're actually using that as a foundation for one of the programs that we've started in our cardiometabolic clinic and really looking at how to drive practice pathways. There's such a plethora of information out there, all of these cardiovascular outcome trials, all of these medication classes now. So these guidelines and consensus pathway actually is kind of helping hone in on if my patient has ASCVD, what should I consider? If my patient has heart failure, what should I consider? So hopefully laying out that foundation and a starting point for the clinician to take it and then individualize it for each patient.
And Peter, that specifically says that if you're at risk for heart failure or for ESRD, to consider a SGLT2 inhibitor, and if you're at risk for an atherosclerotic event, consider a GLP-1 agonist. So they're not really waiting for the heart event. They're saying even at risk.
Right, so these suggested pathways, and we've reviewed them, really do encourage the clinician to stylize based on risk. And I agree with your comments. As patients map towards atherosclerotic cardiovascular risk, the GLP-1 agonists seem very favorable. For patients who map towards renal and heart failure risks, the SGLT2 inhibitors.
Anything else on these pathways, or you agree with other two comments?
Well, the flow diagrams and the color pictures are very helpful, and they become reference guides so that we have things in our white coat that we may have one that's laminated, and so that's a practical thing that's helpful because there's so much information, but then you look back, oh, yep, okay. So that's been a really positive thing in the consensus pathway documents.
Seth, any comment
yeah,
on the ACC pathway?
Yeah, I would just say that it's one of the simpler pathways, and it's easier to follow than some of the other very long algorithmic pathways that we have.
And it was not simple to get it to that process, I can tell you that.
Sure
there was a lot of work went into making it simple.
It really does help.
But it was helpful, yes.